Welcome to the Cold Steel Surgical Podcast with your hosts Amir Farouk and Chad Ball. We've had the absolute privilege of chatting with some amazing Canadian as well as international guests over the past year. While the topics have been broad in range, whether clinical, social, or political, our aims for the podcast continue to remain the same. We hope to inspire discussion, creativity, scholarly research, and career development in all Canadian surgeons. We hope you enjoy our second season as we continue to highlight some incredible guests, deliver detailed masterclass sessions on a myriad of clinical topics, and introduce some fresh new features such as debate and companion formats. We hope you relish the podcast as much as we do.
This week on the podcast, we were lucky enough to be joined by Dr. Clarence Wong. Dr. Wong is an interventional gastroenterologist at the University of Alberta in Edmonton, Alberta, and he gave us a masterclass on his approach to large polyps and polypectomies. In addition, we talked about a number of other work that he's done around screening guidelines for colon cancer, as well as his many simple yet super effective tips and tricks for improving the quality of your colonoscopies. As always, we look forward to your comments, thoughts, and suggestions. Dr. Wong, thank you so much for joining us on Cold Steel. It's really an honor and a pleasure to have you. You are the first gastroenterologist we've had on this surgical podcast. So please tell us a little bit about where you grew up and your training pathway.
Yeah, well, thanks so much for having me. I'm really honored to be the first gastroenterologist on, and I hope I do the rest of my colleagues some service. But I actually, some of my colleagues know this, but I grew up in Calgary, and so if I can relate back, I watched the Flames play in the Corral. I was volunteering the Olympics in Calgary, so I am a so-called Alberta boy. But I did come to med school in Edmonton at U of A, and then I did my internal medicine at McMaster, and I think that was really important because I really learned some strong fundamentals about evidence-based medicine before coming back to Edmonton to do gastroenterology in terms of the fellowship. But afterwards, I did a number of years at the Cross, so I did oncology, not only in a wet lab for some time, and then I also did therapeutics endoscopy, some in Edmonton, but some of it was in Quebec, learning ultrasound. So I've been around a few places, so it's been nice, and I've been very lucky to have trained in multiple areas.
Yeah, it's so true. We talk about that often on the podcast, how helpful it is to do different components of your training over time in different places. Just to, meeting people is one thing, but just seeing different ways that things can be done expands your brain, I think, for a career. There's no doubt. My biggest question for you, Dr. Wong, though, is are you a Flames fan or are you a Oilers fan? How's that?
I've got red in my closet.
Oh, geez, eh? So you and I are flipped. I grew up in Edmonton and, of course, now live in Calgary, and I cannot cheer for the Flames for the life of me. Just can't do it.
Although I have softened because, when you live in a place long enough,
your kids,
it gets to be 1 and 2. My kids are Flames fans, actually, and they were born in Edmonton, so it's actually quite interesting. But I totally agree with you. I think for trainees, I tell them the most important thing and the biggest luxury that you have training in Canada is that you have access to different places. You have access internationally. I think we're really lucky. And I always tell someone that if you train one place, I always see that as, just a little bit of a question mark. Obviously, you can be great, but, there's just so many different points of view. And I think it rounds you as a professional when you do it that way.
Yeah, professional and a human being. There's no doubt. You're very well known, not only provincially, but nationally for a whole bunch of things. But one of the things in particular we wanted to touch on was the screening guidelines for colorectal cancer in Alberta, and in particular your view and the evolution of the FIT test from the FOBT traditionally. So I guess, how did that come about? What do those guidelines look like? And give us a sense for a silly general surgeon like me, how good that FIT test really is. In other words, I remember one of your talks, you had mentioned, if your FIT test is positive, you should find some sort of lesion this proportion of time.
Right, right. So it's within our short careers that people forget how poor colon cancer screening rates were. So I was reviewing some of my own talks, and back in probably 10, 15 years ago, the 2005 kind of report card on colon cancer screening, Alberta was at about 25% of the target population for screening. Like that is just astoundingly terrible in terms
Wow.
of a disease that's completely preventable. And as we all know, every colon cancer, from my point of view, is almost a preventable disease. So if we jump forward, back then it was kind of, do a little bit of FOBT, guaiac, do a little bit of endoscopy, maybe doing some barium. And I think at the end of the day, it confused everybody, and no one got screened. And so for the last probably, no, the next probably 5, 10 years after that, we knew that FIT or fecal immunochemical testing was available. It wasn't quite in Canada yet, but in Japan and in Europe, they were using it. And from some of their literature, it was astounding to see the increase. So we actually brought over a number of experts. One I remember it was Graham Young, who's from Australia, who runs the Australian program. And he really just gave us the pearls and kind of the whys because, as you know, a lot of us in terms of GI and in surgery, we're saying, no, we should just stick to colonoscopy. It's the gold standard. Why would you even look at something else? But the most important screening test in any field is the one that gets done. And I think what we forget about guaiac and colonoscopy is that number one, the FOB guaiac, patients didn't like to do it. It was on 3 separate days. You couldn't have certain dietary things and do it. And the other problem with the colonoscopy is obviously its access. So if you went on a colonoscopy model, sure, the person in front of you or the one that lucky to get the scope would get screened, but a large proportion of the population wouldn't. And so the FIT was actually a good answer to that. It was certainly the sensitivity wasn't as high as colonoscopy, but it was miles better than an guaiac. And the patients preferred it so much. It was so much easier. It was, one test, it was done. And the overall kind of the accuracy rate on one test was 80%. And so if you did that over time, the FIT test was actually very accurate and picked up a lot of lesions.
I think one of the interesting things that you mentioned is that when you're making these screening guidelines, it's not just, how many colon cancers have we prevented or how much more, preventable mortality have we averted. There's all these other considerations that go into it, like, how easy is this for patients to do, or how easy is it for patients to get access to this test? And, there's a ton of considerations that must go through your head and everyone else who is involved in making these screening guidelines. Can you talk to us a little bit about what are the considerations that go into making screening guidelines like this on a provincial level? Like mechanistically, what does this look like? What are the considerations, and how does this get rolled out?
Yeah, that's a great question. And I think it's one of those things that if you asked me, 10, 15 years ago, probably when I was much more naive, it was, look at the evidence and follow the evidence. That's what I would have said. But the truth is, there's many things that when you look at the evidence, you also have to realize, is it applicable to your zone? Is it doable from both a professional point of view, from your endoscopy community, and also from primary care? And so I think, when we actually start to form and look at the committees and the guidelines, that stakeholder input was so critical. And as you both know, you look at the evidence and the guidelines, there is room to shift. And my teachers back at Mac, when they taught me the same thing, says, not everything is an RCT. And in fact, most evidence out there is not an RCT. So you have to realize how to make it the best, applicable and useful for your group. And so when we were designing this, I think, having primary care at the table, having, patient groups and hearing their voice, having community and also academic endoscopists, I think that set of voices in, and everybody had their viewpoint, but how to actually streamline that together to make one uniform set of guidelines was really important. Now the FIT, we knew the evidence was strong, and that was trying to convince people. But even going back to what Dr. Ball had asked about the pickup rate, so we know that when your FIT test is positive, the chances that you'll find at least an adenoma is about 2/3 of the time, which is astounding. And so I know that when we started the test, we had a whole bunch of people that were finishing a colonoscopy, and then they would go back and do it again right away and go to seek them. Say, Clarence, I didn't find something. I was worried. And this is a 50-year-old with a first-time positive FIT. And so it changes the perspective of the endoscopists immediately. And the second part is, again, listening to the public, is that if you gave it to them and they didn't like it, then your test, it doesn't matter what the sensitivity is. They actually had to do it. And what we found is that the patients, by far, when we did the comparison studies, were much more willing to do this test at home. It still has that little bit of the yuck factor because it's a poop test. But the way that we advertised, and that's the one part that I really learned as part of the screening program, is that what were our advertising tactics? What were we doing in terms of design? And so I learned a lot from our designers and people that were actually in arts and public health. And so again, it was a blend. I knew what the strong evidence was, but I think it was all these other groups that actually were really important to make the guidelines complete, and actually make it so that it's accessible. And I think that was part of the reason that I think actually in Alberta we've actually done really well.
Well, one of the things we were going to touch on a little bit is the fact that the U.S. Preventative Task Force has now lowered the screening age for average risk individuals to the age of 45. I guess there's two parts to this. One is sort of building off your answer to the last question, which is what are the sort of things that you think about now when making a shift like that? Like, for example, where does cost fit into these screening guidelines? Because I'm sure that, any of these changes that we make have a cost associated with them. And how do you think about that, and how do you sell that on a provincial level? And then the second part of that is specifically about this age 45. Do you think that's sort of the way that we should be going in Alberta as well?
Okay, so so two things there. So first of all, it was the ACS that actually made that recommendation, so the American Cancer Society, and so they published actually quite a controversial guideline. And with that, they actually showed some data showing that there was it looked like a time shift over, that younger individuals were getting cancer. And so they actually made, it was very odd and very confusing. They made a conditional recommendation. And I don't see that too many times in guidelines, but they said, we conditionally recommend that you start at 45. So in other places, among the big GI societies in the US, in Canada, every province, including the Canadian Task Force, we still at this time stuck with 50. So I just published a review with Academic Primary Care with Mike Colber, and we actually looked at our Alberta data and compared it to a number of other studies. And so what it does show is that there is a relative increase in that younger group. However, when you looked at the absolute numbers were actually quite small. They were, 4 or 5 per 10,000 at most. And actually, maybe I even misspoke. It might even be even smaller than that. So again, linking back to your cost question is that yes, we could start at 45, but for the number of people that we would have to screen, and that we would actually have to, have fit tests and go through colonoscopies, that same amount of money, if we applied that to 70-year-olds and actually encouraged them to get screening, we would actually save the system 10 times more trying to encourage the 70-year-old group to actually get screened. And so those are things that we do look at. It is, being an endoscopist and taking a different part of my brain and being part of the public health kind of brain is you do have to say what's the best for, the system. The other part about colonoscopy, which is, as you know, is different from doing mammography screening for breast cancer, is that every endoscopy may potentially take out a case that's for diagnostic care, somebody with colitis or somebody with, bleeding. And so it's really important to balance those two apart, and that your screening programs aren't actually taken away from diagnostic and therapeutic care. And so I think all of that, you got to try to find the balance is what's the most bang for your buck in terms of the age, and what's the best that you can do to ensure, as much safety as you can for the public. And I think that's what we've been trying to balance. And it's an ongoing thing. This is something that when it came up, we chatted across the country with every other screening program to get everyone's sense of where we were going. And I think right now we all are agreeing that we're seeing the slight trend, but it's not enough, we think, to change the guidelines in Canada.
Yeah, it's such an interesting and fascinating area to kind of think about. I did want to specifically, while we're still talking about screening guidelines, one of the things that I think gets confusing for trainees, especially surgical residents studying for their Royal College exam, is kind of getting their mind around intervals for screening. So let's say you've done a colonoscopy, you've found a certain number of polyps, a certain number of types of polyps, and then you're trying to figure out what the interval should be for a repeat endoscopy. Is there sort of an approach that you have in your head that you teach trainees that helps people to remember this? And are there any helpful sort of guidelines or resources that you point people towards?
No, a great question. I think that fundamentally to make it a little bit more binary to start with, is we recommend that when you actually remove or see polyps, separate into low risk kind of polyps or adenomas and the high risk adenomas or polyps. Now, I think once you have that split, it really, it's actually separating even further in terms of how you manage these patients. So the standard, you see a patient with a 6 millimeter adenoma, that's a low risk adenoma. And actually the evidence is showing that the high majority of the time, even if you never remove that polyp, you probably did change that person's lifespan. And so even though you might feel, great, okay, I took off one or two of these little polyps, frankly, they probably don't. And in fact, the guidelines are shifting for that, is that if it's a low risk adenoma, again, it's less than a centimeter, there's only one or two of them, and the patient has no other family history or other risk factors, a lot of places around the world are actually shifting to the next interval being an FIT screen. So in Alberta, the current guidelines are still, if you see a low risk adenoma, repeat the colonoscopy in 5 to 10 years, so even a longer interval. And in Ontario, they've actually made the switch to say that if you removed a low risk adenoma, just go with FIT testing in 5 years. Now, it was controversial in Ontario. Certainly a lot of people were shocked to move that way. But if you actually looked at the evidence, the amount of life years that you would gain from repeating colonoscopy, let's say at every 5-year intervals, it starts to actually get into a point where are you actually causing someone to enter the system more and potentially complications rather than saving them the risk of colon cancer. Now, the most important thing, again, the other part again of the binary set is the high risk adenoma, the high risk polyp. And so I make all my residents, right from the first year that I see them, memorize, what's a high risk adenoma. And there's a couple of criteria. Does it have anything that the pathologist says is high grade dysplasia or intramucosal carcinoma? Is it over a centimeter in size? Are there 3 or more of them that you found during the time of colonoscopy? And do they have any villus elements? And once you have any one of those criteria, most of the guidelines would tell you that that's a set that you have to be more careful about. That's probably a group of patients that you need to bring back at least within 3 years, if not shorter. So in fact, if most of us that see routine polyps, that actually is the group you should concentrate on, not the 1 or 2 small adenomas and you just tell the patient to come back in 5 years. So we actually did a study in Edmonton where we actually looked at interval rates among GIs, looking at the recommendations, and it was kind of all over the board. It was even for the high-risk lesions, a third of them actually brought them back too early, a third of them were at the right time, and a third of them, to me, the most scariest stat was the third of them were late. So I really think that the education is, again, low risk or high risk, and then make sure that those high-risk ones come back early. And anything that's over 2 centimeters is an advanced lesion. And that one is that if you're doing any sort of piecemeal resection or that, it needs to come back within 6 months. And there's many guidelines for action now saying that if it's over 2 centimeters and it's flat, you should be sending to endoscopist that actually has extra training. And so that's something even within the GI community that we're trying to stress.
Can I ask you in particular about serrated adenomas and how they maybe differ from run-of-the-mill adenomas?
Right, that's a great question. That's probably one of the most confusing things that's come up in the last 10 years. And actually, I've given a number of talks even to primary care. Because for primary care, all of a sudden they're starting to see these reports come through that says, oh, sessile serrated adenoma or polyp. What is this and how to deal with it? I think the significance of the SSP or SSA, as we'll call them, is that they are funny, is that they do have some elements that look like a hyperplastic polyp, but they actually do have some areas that actually look like an adenoma. And I think that's why there's a crossover. But the main issue with them is that when you look at studies that actually look for full resection and recurrence, SSAs, these SL serrated adenomas, always have higher remnants. And so it's actually quite scary. There's one study done that even, if you're looking at residual polyp, when you're moving an SSA over a centimeter, a third of the time there's going to be some remnant polyp left. And so it needs to be taken, with a higher degree of, care. The other thing about SSAs is that we think that they probably are linked to those higher rates of a right-sided colon cancer. They tend to be flat. They can be very hard to visualize. And if your bowel prep isn't perfect, if you don't, if you're not nice and careful, that's one of those things that you'll miss. And even in those cases where people ask me about even things like CT colonography, I say, well, the one issue about CT is that it would absolutely miss sessile serrated adenomas because they're so flat. And this is where a really careful endoscopist that's taking their time, that's the best defense about finding these lesions. We find that I think for most people that are looking for these, you have to make sure that you wash the lining well. They can be covered with mucus, and you just think it's a bit of mucus, and underneath is a large flat polyp.
Since you mentioned it, and we were going to ask specifically about CT colonography, where does that fit in general in terms of test performance, maybe beyond serrated adenomas? And then I'm also curious what the variability, if you know, sort of across the country would be in terms of using CT colonography. And the reason I ask, of course, in Alberta, it's extremely challenging for a primary care practitioner to order that out of the gate. It sort of has to come through GI or through surgery to obtain.
Yeah, that's a great question. And I remember back in Edmonton, the Cross, we were one of the first centers to have CT colon. That was again, probably 10, 15 years ago. And the funny thing is that we used to do a case and you'd go home, you let the computer chug for 8 hours to generate one set of images. And then my joke is, Pixar came along with, higher chip speeds and computers, and now you're flipping these, so much faster. But I still think, if you look at the evidence going back, if it's a polypoid, a pedunculated polyp, something that has a good sessile mass, CT colon is pretty good at picking those up. And so most of the guidelines will say, something that's over 6 millimeters in size and at least sessile, the rates of confidence are actually not bad. They're actually pretty good. Again, the biggest downfall has been, these SSAs. And we actually think that the SSAs are a big cause of probably right-sided cancers. Now, in terms of across the country and kind of accessibility, you're right, it does vary quite a bit. And in most cases, I would say that we're recommending CT colon in cases where the optical colonoscopy is not possible. So very redundant bowel, you can't reach the right side. I've had a couple patients that have had radiation and strictured the left colon and you can't see. I think those cases for sure. But in terms of that other sense, if you're going to order it for screening, I don't think that we're there yet. I don't think many places around the world would actually reach for that as a primary tool. Some societies do recommend that's one of your a mix of possible things. But again, I think unless your center was really dedicated and had radiologists really committed to that, sticking with a simple plan of FIT and then colonoscopy is simpler, it's easier, and I would say there's more evidence to that. So as you know too, Dr. Ball, in Calgary, because you can buy your own, you have some patients that are buying their own CT colon.
Hmm.
But again, if there's anything that's found, they're re-prepping again because we're not there yet to have somebody prep for a CT colon and then have them have their optical colonoscopy at the same time. So those are a lot of things that even when I discuss this with my patient, they'll say, you know what, I don't want to do prep twice. I think I'll just wait and just do the optical.
So we wanted to shift gears a little bit and talk about something that we were chatting about a little bit before we went on air, which is sort of how we can maximize the collaboration and the coordination between gastroenterology and general surgery. Because I think one of the big issues that remains particularly a problem, or I should say just a reality in Canada, is that most of the colonoscopies being performed across the country are still being performed by general surgery. And, I'm curious about what your thoughts are about how we can improve the quality of the endoscopy that's being done across the country. Like how much is enough volume in residency for general surgery residents to be confident that once they go out into practice, they're doing a high quality job and they're doing good quality colonoscopies. Do you think is it a volume issue that they need a certain number? Are there other things besides volume that you think need to happen? What are sort of your thoughts about general surgery training, particularly within endoscopy?
Right. No, it's a great point and question. To me, for sure, if you look at the statistics and going across, general surgery takes care of a high majority of patients, not only in Alberta, but around the country. And oftentimes, they are also the main endoscopists in more rural settings. And so when we were looking at our grid map at where colonoscopy was done, it's pretty obvious that what you have to do is you have to make sure that all endoscopists, whether it be general surgery, sometimes even primary care or GI, are aware of the proper metrics, are actually trained up. And I always said that my goal when I was the head of colon cancer screening is that we need everybody scaled up to that certain high level. That being said, I do think that in the community that endoscopies are done well. That's generally when I look at the stats. Getting in, I think you're right, is the hardest part. And what I find is that initial transition from training to the first few years of practice, that can be where it's trickiest and it's hardest for people. So in terms of numbers, we bantered around numbers around GI and general surgery for a long time. Some groups like I think American Board of Surgery have lower numbers like 50. Some people up here say you have to have 200. And I think we're getting away from that straight number because as you and I know, when you're doing a procedure, there are some people that have a much quicker knack of picking it up. Some need more time, and with something like colonoscopy, there's many things. There's the technical elements, but the other part for me that's also important is that visual elements. Or even though you can reach the cecum in 4 minutes, do you have enough of a visual history that you can actually pick up lesions? And to me, that probably is more of an important skill that you learn over time. So I think what we're moving to, and I'm sure surgery as well. I was just on meetings this week. Is really competency by design and observed colonoscopy, and I think that's a much better tool to actually assess how somebody's doing. So, for example, for our GI trainees, now we're actually looking at a number of really set metrics, not just numbers. So we have a trainee, if they, for example, did 100 colonoscopies, but their tip control wasn't still good, we're actually using that as a metric to say, you know what, we're not going to pass you on this level yet until you can actually show that you've got some better tip control. You're not, pushing a lot of redundant scopes, that you actually are showing the ability to stay centered. So I don't know exactly how surgery is thinking to this, but I really think that that's, to me, an evening field among all different groups that are doing endoscopy, is that we should be actually assessing competence. And I think any experienced endoscopist, whether you're in general surgery or GI, you'll have a pretty good idea when you watch someone do an endoscopy whether they're going to be competent or not. And then to really break down, so, it's what I call conscious competence, right? Being said is, do you know what you're doing that's good? And do you not know what you're doing that's good? And then the other way around, that, what you don't know, you don't know. And so I think when we're teaching now and I'm assessing trainees for endoscopy, those are the things that I'm trying to tell them, teach them is that, do you realize that, you weren't looking at that step, or do you realize that, you may be a little bit fast, and did you see enough? What do you think about that lesion? Could we talk about that quickly for a second? So I think we're probably going to move past the straight numbers thing and in fact, I think if we do that well among all endoscopists, we're going to be training much better endoscopists, whether they be gastroenterologists or general surgeons. So I think, I would say I was not skeptical, but I was on the fence about the competency by design. But actually, now that we've got a few years and I'm training GI residents, I feel that I'm a little bit more on top of them in terms of actually giving them direction instead of just saying, oh, what are your numbers today? And you did 6, so okay, that's okay.
This is maybe a bit of a controversial or difficult to answer question, but I'm curious if you have general surgery residents come rotate with you and do scopes with you, and what do you think are the big things that maybe differ in the way that GI sort of approaches scopes versus general surgery, or maybe that distinction doesn't really exist?
Yeah, I think that's a good point. So we used to train a lot of general surgeons doing that. In fact, it was one of at our sites, one of our pride things is that we did train people across, and unfortunately, it was more of a numbers game rather than who was training who. We were actually having troubles getting enough time for trainees to come through. In terms of the differences, you're right, as I think that if you look at how people are thinking about what's happening at the end, it's that after part. It's that how are you continuing to improve your skills? How are you actually picking up maybe newer techniques? Are you using the most up-to-date equipment? Those are things that I think are more important than just looking at how you're getting trained. So, for example, one of the things that as I've done reviews across the province is that I looked at what your equipment, and I had some places that were using 2-generation old scopes. So I said it doesn't matter how good of an endoscopist you are, you're actually using old equipment, and why wasn't that part of your assessment of what you were doing? The other part is I think when we were having our general surgery residency come through, I was actually much more adamant to say, you should do a bit of consults, look at the cognitive end, and that actually will help you in terms of the endoscopy, because that'll actually show you, what you're seeing and how that actually applies back. So that may be the other big difference, is that certainly if you're on a GI service, you're going to see, those types of pathologies that you might not see on just the general surgery service. And so I actually think that if we could, to have endoscopists go both ways. I also said going the other way is that I really wanted my GI residents to do a bit of a general surgery rotation. I thought that was actually really helpful for that group that did that as well.
Yeah, that's well said, and it speaks to collaboration moving forward, which I agree with you. I think is getting better and better over time. Having said that, regardless of whether you're on the surgical side or the medical side, and you did touch on it a little bit, what are the key quality metrics that we should think of as standard, whether we're running a colonoscopy program in Timmins, Ontario, or Medicine Hat, Alberta, or in Edmonton at the U of A in a big quaternary care facility? What are the sort of the basic minimums, the bread and butter?
Okay, so it's really funny you mentioned that. When I was doing the tour around the province and looking at how people were doing endoscopy and trying to mention that, it's really a lot of basic things. So starting a database, starting to look at what you're doing, whether I went to Edmonton, Calgary, or Grand Prairie, one of the most basic questions I asked was, what is your indication for endoscopy? So similar to what surgeons are doing for ACATs, we don't have that yet for colonoscopy, but why are you doing it? And I think if you can start to even answer that and have some principles, that is probably the most important thing. And I think for surgeons, you're right, is that you wouldn't ever think about a surgery unless that indication was absolutely correct. And so why is it a different rule for endoscopy? You really should be sure why you're doing it before just jumping in. And so that question, even in my time, has still not been answered. And so one of my big pushes over the last 1 to 2 years has actually been pushing that that indications and that set of coding. And so we actually are going to push that endoscopy is on the ACATS list, and we're actually looking at that set of guidelines to answer that. So that's the first of all. So why are you doing it? And, is that the indication appropriate? I think the next thing is obviously most people think about technique and metrics. So they think about, cecal intubation rate, time in and time out. But obviously the other part is that it doesn't matter how many times you hit the cecum or how fast or slow you are. If you're not detecting cancers, that by itself, it doesn't matter what your level is going in. And so the basic kind of technical things that we measure for most people are how many times you reach the cecum, obviously what's your complication rate, what is your sedation rate, because we're moving for that. And then on the other end, which is the more difficult part, is looking at what you're finding. So what's your adenoma detection rate? If you don't have a pathology report to go through, what's your polyp detection rate? And at the end, the most important part as part of a screening program, it's what's your cancer detection rate. We actually looked at it a little bit differently. We issued provincial report cards that we're trying to replicate, but we did issue a one-time assessment of post-colonoscopy colon cancer. So these are ones that you would have had a colonoscopy for, but within 6 months to 3 years afterwards, that you actually a cancer appeared. So by definition, it might have been missed on that index. But those are the things I think to really think about broadly for most people that are doing this. Again, count why you're doing it. Look at some of the technical aspects, but then third, look at your results. Because otherwise, and going back to that issue about the volume, some of the people with super high volumes weren't necessarily the best ones at detecting cancer. And so those things actually have to be separated. And I think we have to be good in all three of those spheres. Choose the right patients, do the right technique, find the right lesions.
I think that's really a good way of kind of thinking about it, because I think even when I think in my mind about quality metrics in colonoscopy, I'm always thinking about cecal intubation rate and ADR. But you're so right that there's step one is who are you even choosing to do a colonoscopy on, because that's really where you the decision is made is even before they get in the endoscopy suite. It's interesting. In BC, they've started this directed observation of procedure skills, or DOPS. I think I messed up the acronym, but basically they have a program in place where they actually will come and observe you doing colonoscopy, and you have to get that every certain number of years as sort of a quality check and to make sure that you're sort of up to par. Do you think that's something that we should be moving towards in Alberta, and what do you think are the benefits and potentially some of the barriers to doing something like that across the province?
Right. Yeah. The DOPS has done in BC has been done extremely well. And I've talked to their cancer head, which is Dr. Jen Telfer. I think she's done an amazing job. And the reason that I think it works really well in BC is that it's a wide collection of different groups. So it's not GI, it's GI and general surgery. It's not just academic, it's academic and people in the community. And they actually took some people from the city and some people in the rural. So the committee was really mixed. And their mandate, when you're setting something like this, you got to be really careful what you set your mandate on. Theirs was really more set on improvement and actually skills enhancement rather than being kind of like the police force. And I'm going to come in and tell you who's going to be able to do endoscopy and who's not going to be. And I think when you set it at that type of mandate, people that I've gone through and I've looked through their reviews, that everyone that comes through that says, it's a little bit scary, having 2 or 3 of your colleagues watch you. But at the end of the day, I'm a better endoscopist because I got, really good directed feedback. It was good constructive things for me to work on. And it really highlighted to that group that, and I think Dr. Ball mentioned this earlier, that things change and techniques change. And if you're just working in your own little center and nobody ever comes in and actually shows you how something else different is done, how can you pick this up? For me personally, I'm a much different endoscopist than I was when I finished training. And I would say that every year I learn something else a little bit new, some little technique. Even the way that I'm holding an endoscope now is different than I was when I finished. And so these are things that actually have evolved with time. The DOPS really helps that because it's a really broken down way of how you're actually positioning the patient, positioning your endoscope. What are some real metrics of how you're actually visualizing the mucosa. And so I think that it's, if we can adopt it, it's a really great way of, number one, assessing who can come into the system. And number two, that it's a nice check as you're, every 2 to 3 years to actually do this. The biggest problem with DOPS is cost. I think, these things don't happen, unfortunately, for free. You're taking out some very experienced individuals and you're having them go to different communities to do this. And so I think that is the biggest challenge. But at the end of the day, and if you look at how they've done it in BC, every place that they've gone through, people have been so happy about the results. And again, if your base thought is that people are good endoscopists and they're carrying out there and you want to improve them, this is how I think you should do it, to have a good DOPS. So in Alberta, we try to do more of a multidisciplinary kind of endoscopy conference. That's kind of the closest thing we have. But I really think that we need to be moving towards the DOPS model. It's just, again, one of the things that I have on my list of trying to convince our health authority that this is a good investment of money.
I think that's so well said. And I couldn't agree more, to be quite frank. Mentored observation, or whatever term you want to apply to it, is critical to improvement, but it does require some humility and some self-confidence and some willingness to try and get better. I would love for someone like you to come and watch me do a colonoscopy and tweak me. And I'm reminded of a really neat article that Atul Gawande wrote, from Boston, where he was doing an endocrine procedure and he had a very senior, recently retired surgeon just come in, and this sort of icon of surgery was taking 1,000,001 pages of notes, and he was thinking, what am I doing right? What am I doing wrong? And, he beautifully, as only he can do, describes that that process and that experience and how much it improved his operating. And that was just sort of one exposure. And I think we all probably should seek those opportunities out a lot more than we do. One of the things you had mentioned was sort of defining an advanced polyp. And I'm curious how you assess resectability for an advanced polyp, with the understanding that you're a very skilled interventional gastroenterologist with a skill set that not only will exceed, obviously, most gastroenterologists, but the vast majority of surgeons. So I'm curious how you look at that. And really what I'm getting at is, if I'm doing colonoscopies in High River, or again, going to go back to Timmins, Ontario, when should you stop? In other words, when should you pull the chute and send that patient off to somebody like you with a vast array of skills and knowledge and to be quite honest, probably different equipment on occasion as well?
Right. No, that's a great question. It's something that, when we cover at our conferences, we talk about a lot. And there are actually fairly recent guidelines from the USPSTF actually on surveillance, but also there was another subgroup that actually looked at polypectomy performance. And from the evidence, it's really, really clear that if you're looking at a lesion over 2 centimeters of size, it should be considered an advanced lesion. And in fact, in the colon, if it's sessile-ish in terms of or at least semi-pedunculated large, that's something like that we're calling an LST, or a lateral spreading tumor. And once you get into that range of 2 centimeters, you should be sending it off to somebody with more experience. Now, even in our community, in our GI community, we're having a difficulty of convincing some people to do that. But some of the things for an advanced endoscopist to look at is number one, just in the amount of time and experience we have looking at the lesion. Most of us across the country that deal with mucosal lesions, whether it be in the esophagus, stomach, or colon, say that, before we jump in and you're looking for snares or whatever else, look at it under, careful, high definition endoscopy. Use the chromo or virtual chromo endoscopy. Most people don't even know where the narrowband imaging button is on their endoscopes. Look at that assess it, and then think about, are there elements maybe of deeper cancer? Because the biggest mistake, I think, for most people is starting a resection and then abandoning it. And that's probably the most common type of, I would say, a bit of a mistake that I see from the referrals coming in the city or from the periphery, is that people get into it and they realize they're in trouble. It's never, other than the patients having to prep again, it's never wrong to pause, to look at it, take pictures, bring it back out, and then just tell the patient, what, we got to book this back again and do this right. I think if you're looking at a standard 30 or 40-minute time slot and you're trying to resect a 2 centimeter polyp, almost any expert across the field will tell you you don't have enough time to do that correctly and safely. Whereas if I get one of those lesions, I will book off the time to make sure I'm actually just being careful, looking at it, and actually using those techniques. So as a good general rule, if you're looking at a sessile lesion over 2 centimeters, you should be really careful about not tackling at that time. The second issue is about biopsy. Now, in the therapeutic field, there is some kind of a bit of, I would say, controversy of what to do. Some of the, I think what I call them the purists, because I obviously don't agree with them, would say, never biopsy them, just, maybe tattoo distally and send it off. The problem with that approach is that I've had some people send me cancers. And so that patient's been waiting to see me for 1 to 2 months. I take a look and I say, oh, I wish the biopsy was done, because that's clearly a cancer. That's not a resectable lesion. The other way, or the other problem, is that some people really go at it with the biopsies, and they biopsy it so much that they actually tack it down. And so my kind of compromise is, as I'm telling people when they're looking at these, take a look, take a bite, or just 1 or 2 bites of the areas that you're most worried about, if I'm not close around or accessible, and then, like say, tattoo distally. And that's actually the other part too. And I think I was doing actually a study with one of your residents in Calgary. There's a number of people that are still tattooing under the lesion, which completely wrecks all resectability planes. And so those are the things kind of to think about before sending it on. The other thing too is just take pictures, like take lots of pictures. It's you say you probably won't be surprised, but I get these referrals, large polyp and rectum. What does that mean? So how am I supposed to triage that and get a sense if that person should do a full prep? Should I bring them down from, again, high level, book for 2 hours, or just book that for 15 minutes for a SIG? And so all these things, and in Ontario, what they did is actually they did a checklist when you're looking at these large polyps, and I think maybe that's one of the approaches that we may need to take in Alberta as well.
That's very well said. And, again, in full disclosure, there's almost nothing worse, I think, maybe than being engaged in a colonoscopy and trying to take out something piecemeal. And as you say, being halfway through it and realizing you shouldn't be doing it. That's an experience, I think, that none of us want to feel at any point.
Yeah, for therapeutic endoscopists, and I teach my fellows that just remember you got yourself into this. So number one, you got to get yourself out of it. Or number two, you got to ask yourself, why did you make that first cut? And was this the right time to do it?
So we've talked a lot about kind of assessing these advanced polyps. I'm curious, and we chatted a little bit about this before we started recording again, but one of the things that was started in Calgary was this advanced polyp committee, where big polypectomies, or rather big polyps that were being considered either for some kind of advanced endoscopic procedure or for a formal surgical resection, were actually being reviewed on a regular basis by a multidisciplinary committee consisting of gastroenterology and surgery, and they would actually review these polyps before a decision was made. Do you think sort of that's the way that we should be going? And sort of what are your thoughts about how we can improve our ability to make the right decision on an individualized basis for these patients?
Yeah, I totally back that. I think that is absolutely the way to go. Like I was talking with Dr. Ball on this, is that in the cancer field, you'd always make some multidisciplinary decision of what to do. Before I put in esophageal stents, I'm talking to the radiation oncologist, I'm talking to the thoracic surgeon, what order, what should we do? And I think there's really no difference with these large polyps. They are early neoplastic lesions. I tell my fellows when they're with me that, you screw up the resection, you could have screwed up the planes and all the staging. And so I think the approach right from the beginning has to be multidisciplinary. As well, there's choice, and I think there's not necessarily a wrong answer of which way you go. You just need to have an idea of which stepwise way, that you're going to approach things. So, for example, a large rectal lesion, like I say, it could be TEMS, but now we have ESD. So, which one, is better than the other? And as well, in your center, you may have someone that actually, does a lot of these or not. So, I really think that whether it be in the colon for chronic large lesions or even in the upper GI tract, that you should have a good multidisciplinary team. So for myself, I do a lot of upper GI resections as well. We've been doing Barrett's and resections of early esophageal cancers for well over a decade, almost 20 years now. But I would say that my most important partner is thoracic surgery. So we discuss all of these lesions and whether I should do it or not, whether they should do it. A lot of times it's funny, they're pushing me to do it and I'm saying, I'm not sure I should be doing this. But I think you need that healthy back and forth to really make the best plan for your patients. And when I'm telling them and I'm sitting them in clinic, I said, just let you know, we've had about 4 brains think about your case and have tried to give you the best recommendation. And so I think the more collaboration that there is, the better outcome there's going to be for patients. And also the other part too is that I feel like I'm backed up in every one of these cases. It's not just me. We've gone through this. I've tried my best. And if, it goes well or if it doesn't, at least you've got your team behind you to say, what, we made the best choice possible with what we knew.
Yeah, it's amazing how much of surgery and medicine is going towards that kind of model. And I really think that just is so important for us to break down our silos and reach across these traditional divides, geographic divides in our minds, so that we can really give the best care for our patients. I know this is a big topic, and you've given us a great talk on this for the residents in Calgary when I was there. But I did want to get your tips and tricks for the difficult polypectomies. Can you walk us through when you're looking at a sort of an advanced lesion like we talked about? What are your sort of tips and tricks on how to approach it? And I want all the details, like, are there any positioning tricks, snare tricks, and even down to things like should we be using coag versus cut? So if you could give us some tips and tricks, that would be fantastic.
Sure. So I would say the most common thing that most of us are going to see is probably that 8 to 10 millimeter polyp. So let's say the 1 centimeter polyp, and that's a good polyp that anybody should reasonably tackle and do well. So I think number one is, again, it's all about positioning, because it doesn't matter how good you are with your hands or snare. If that polyp is in the wrong spot or it's sitting in a pool of fluid, you're not going to have a good resection. I'm referred lesions that say, 1 centimeter polyp, and then you could tell that, you didn't look behind the fold, and behind the fold, there's another 3 centimeters. And so that's just a matter of, again, that you don't need a therapeutic endoscopist. It's taking the time to really look at it and to position it well. In most cases, the number one thing that I look at for a polyp is try to move it to the 6 o'clock position. That by far is the easiest way with the instruments coming out of a standard colonoscope. And the next is that if there's fluid in that plane, I will turn the patient. And so use gravity to help you. Flip it so that the fluid is actually going away from the polyp. And the other part too is that when you resect the polyp, it's also going to fall into that pool. So it's not going to sit within the same area. So number one is get your positioning right. The next thing is that, again, your choice of a snare, you need to really know your equipment. I bug my therapeutic fellows all the time. Tell me what snare you're choosing and why. Is it a cold snare? Is it thin wire? Is it a medium snare? Does it actually have a hexagonal edge? Is it just, a standard band? There's such variety now that, when I first trained, it was like you're given a snare and there's like the one snare. Now there's potentially, in a lot of departments, it could be 5, 6, 7 different types of snares. So choose the one that's going to fit the lesion that you can resect. A lot of time now, just to be honest, is that I'm using the thin wired cold snares. I think that's really been revolutionary in this field. It's really changed how we approach polyps. So even up to a centimeter a polyp, if it's sessile, I'll go at it with a cold snare. I won't even use heat anymore. So that's really, really changed. The next point about injection, there's been a lot of evolution in this field as well. So number one, with the large lesions, and these are again 2 centimeters or more, we're actually recommending a viscous fluid injection. So if your unit doesn't have it, then it's Voluven. But there's actually two commercial products available. There's actually in Canada, we're really lucky to have something called Eleview and the one called ORISE. And in all the studies that have looked at viscous submucosal injection, you have actually less complications, less residual polyp, better ability to actually resect the entire lesion. For a 1 centimeter lesion, if you think you can do it fairly, with a reasonable amount of time, saline is fine, but I always tint it with methylene blue. I think to me that's a really important step, because that little bit of blue tinting helps you see whether you've got actually the entire edge. And then when you've made the cut, to make sure that you're not perforated, and through muscle. There is some evidence to show that if you put dilute epinephrine, 1 in 100,000, it may prevent post-polypectomy bleeding. Most 1 centimeter polyps, I wouldn't do that. The larger ones, I'm actually starting to do that. We talked a little bit about the hot and cold. I'm saving the hots more for against the larger ones, but for almost anything a centimeter and under, by far, cold polypectomy with the new thin wires, it is the way to go. And in studies, it's safer and it allows for a cleaner inspection of the edge. I think you'll actually leave less polyp. You asked me about the electrosurgical unit. So number one, make sure that you are using an electrosurgical unit that's actually computerized. There shouldn't be too many of those old Valley Lab type of units out there. And in most cases, for the cut, we're using what's called the endo-cut function. I think that a lot of us that started with coag, but the problem with coag is that you can really transmit a lot of energy deep to the muscle. And so the rule is, get the cut first, and then if you have to, you can use what's called soft coag on the edges to make sure that you don't leave any remnants behind. So I think that's kind of the top to bottom, what I think about for most approach positioning. And in most cases now, I would say that the cold snare has really revolutionized how we're actually removing polyps.
What are some of the avenues that we can maybe engage in or pursue as average general surgeons to try and improve our skills and improve our technique and improve our endoscopy units, regardless of where we're located?
Yeah, so I think there's a couple of things that can be done, and certainly in the province when I was going around trying to help endoscopists get better, and again, it'd be surgeon, GI, internist, or primary care, anyone doing endoscopy. Number one is that in Alberta, we do run a endoscopy skills course. So actually my co-chair is actually a family physician, Mike Colbert, who does endoscopy out of Peace River. And we've actually done a very inclusive curriculum. It's general surgery, again, primary care, some GIs that come. And actually, when people get there, they realize that, at the end of the day, it doesn't matter where you came from. We're all endoscopists. We're all trying to get better. And the faculty that I bring in, they love this group. They said, sometimes it's even better than a full GI group because this whole group just wants to learn and they want to be collaborative. And so, again, learning from each other. One of the stories was, why do you have that thing dangling at the end of your scope? Well, that's a different trap. Oh, I never saw that before, So learning these little tips and tricks with each other. The other part is probably a formal course. And again, we're lucky in Canada that the Canadian Association of Gastroenterology, and I think they've actually got a partnership with CAGS about this, there's a colonoscopy improvement course, so it's called the C course, and they actually have a polypectomy course as well. And this is a really designed, focused, observed endoscopy with a set of skills. I've done it myself. Again, it's daunting to have a couple of your colleagues watch you, but at the end of the day, you come up with a slightly different golf swing. It's sometimes a little bit hard to do it right away, but I have no doubt that, when I did that, I came out as a better endoscopist at the end. And just always remember that, as you said, the equipment and the skills are changing. The field is not static. What you learned 15 years ago, if you haven't changed, is probably out of date. What we're teaching now is way different than when I first started. So I think really look at these courses. They're worth the time. And the other, if you don't have it, is to go to some of these endoscopy courses, which we actually do have available, whether in Alberta, I know we do it in some other provinces as well. But really, talk to your colleagues about things like technique, because I think bringing it in the open and talking about it, you will learn a lot from your colleagues.
Thanks once again, Dr. Wong, for such a brilliant masterclass on all things endoscopy. just in closing, if there was anything that you could tell the average general surgeon about colonoscopies that you've noticed from watching people across the province that maybe is not that intuitive, what would those things be, besides all the things that we've already talked about?
Yeah, it's a good question. So it's interesting that, again, most people I think about skilled and cecal intubation and things like that. And so in fact, I think it's actually the opposite, is that most endoscopists I see in the province are very astute and very good at reaching the cecum. I think two of the things that they don't think about are all the ancillary things. So one of the projects that we took on with the province is actually harmonizing bowel preps. I hate to say it, a non-sexy project, no one thinks about it. But when you actually look at post-colonoscopy colon cancers, one of the highest reasons that people got it was that their bowel preps were poor. And so, people think about their technique and skill, but did you actually look at your bowel preps? Like, why did you choose it? Is it evidence-based? Is it because your preceptor told you to use it? Is it printed in 10-point font that your 73-year-old patient can't read? So that by itself may improve your pickup rate more than anything else that I can teach you. And so our harmonized bowel preps were actually done again with a designer, looking at the evidence, looking at the balance. We had actually patient input into this design, and overall tips and tricks of how to actually drink the preps. And so it was done with the best possible evidence there. So I think number one is just think about using the right preps. The second part is I think the other biggest change with endoscopy, like anything else, is really just take the time to actually withdraw slowly. And the evidence is really clear about that. And when the evidence first came out, we had a number of people that were kind of wondering, oh, well, I'm very careful in inserting, but it is really clear, a slow withdrawal will pick up from the cecum, will pick up more lesions. So I tell people, just take your time. We shouldn't be racing in and racing out and running to the next case. Is if you're going to do this, make sure that you withdraw slow. And if your unit doesn't have it already, use CO2, because your patients are going to be so much more comfortable if you do it that way. So I think if you think about those two things, other than just insertion, it's going to make you a better endoscopist without actually even attending a course to start with.
You've been listening to Cold Steel, the official podcast of the Canadian Journal of Surgery. If you've liked what you've been listening to, please leave us a review on iTunes. We'd love to hear your comments and feedback, so feel free to email us at podcast.cjs@gmail.com or connect with us on Twitter @CanJSurge. Thanks again.